Hey everyone, this is Dr. Brian Schwabia, the student physical therapist. Today's episode, we are going to talk with Zack Cogen. He is a board certified sports physical therapist, doctor of physical therapy, and one of the few Division I sports fellows that has completed a fellowship with USC. So Zack, welcome. Tell us a little about yourself.
Thanks a lot, Brian. Looking forward to speaking with you guys. So I am originally from New York. I moved out to LA about 3 years ago to pursue sports residency. Wasn't a particularly straight road and straight path to get to residency. It took me pretty long time to just even get into school. So just a quick background, it took me about 3 years of applying to schools, got rejected several times in a row. We just remained persistent, worked as an aide for a while, and I finally pushed through that barrier and finally got there. My GPA wasn't high enough for some of them. As an athlete myself, as most of us get into sports PT are, I've been to PT billions of times for every injury under the sun, and in wrestling, just the sheer nature of the sport, in collegiate athletics, just getting after it every day, put the grades on the back burner, kind of just focused on being an athlete and practice and stuff like that. And, halfway through decided to pick up the pieces and say, hey, I knew I wanted to be a PT, and if I kept going down this road, probably wasn't going to happen. So I decided to, flip the script and push forward and, put myself out there, tried to get a bunch of experiences along the way, and finally pushed through the barrier. So as a student, my first exposure to true sports PT, I was one of the few people as a student, to do an internship or volunteership with the Olympic Training Center in Colorado Springs. So I helped out with their sports med research team over there as a student for about 2 months, and I fell in love with the place. It was amazing. And I really got a good exposure to exactly what sports PT is about, sports medicine as a whole, just because we have, collectively in that facility, it's just all disciplines under the sun working together in one unit. And I fell in love with it. So, I picked that up and ran with it and decided sports residency was the route for me. So moved on to sports residency and moved out to California, completed my sports residency at Glendale Adventist Medical Center for a year. Extremely unique facility with about 28 physical therapists under one roof, which was pretty awesome. So, I had 3 mentors along the way, but in an office of 28 people, everybody was kind of your mentor. So it was awesome getting to bounce ideas back and forth, getting feedback from, several different, thought processes and brains. So it was excellent. And towards the tail end of my residency, I was presented with the idea to potentially apply for the fellowship, and I spoke with fellowship coordinator and director Amy Diaz from USC, and she thought I'd be a great fit to apply. And I pushed through, and I finally found myself in that position. So I prior to taking on my job I'm currently in, I spent about a year and a couple months at part of the fellowship and working as a PT for UCLA athletics. So it was an outstanding experience and brought me to where I am today. So I am super grateful for where I am, and I'm excited to kind of get the ball rolling even further in my career.
Yeah, that's a unique experience. So you went from a residency right into a fellowship. And I think what would be interesting to talk a little bit about, if you're open to it, is tell me what that Division I fellowship's like, because the only one that I'm familiar with USC's as well, because I went through the residency in 2013. But I don't know a ton of details about it, and I know it's kind of evolved over the years. Can you tell us a little bit about USC's Division I fellowship?
Yeah, so essentially what I did, I was a physical therapist in Division I athletics, kind of convoluted in a sense that it was USC's. They were kind of on the administrative side of things, but I ended up actually being a treating physical therapist for UCLA Intercollegiate Athletics. So I spent essentially my time there at the facility on campus, and my mentor was rehab director there. His name is Jeremy Vale. So he's PT athletic trainer, and he's been rehab director there for about 10 years. And essentially, I was a working physical therapist working with 18 other athletic trainers, 17 athletic trainers, working with strength conditioning, nutrition, dietetics, everything under the sun, consulting with physicians, really learning about what true sports medicine is, and not just what, sports physical therapy is, which, I got the good gist and, very broad context of what that is in the residency, and I start to learn about what goes into the management of a Division I level elite caliber athlete, which was, that was the whole experience in and of itself.
Yeah, which is unbelievable.
Yeah, so it really challenged me, personally, professionally. Learned exactly what involves from a return to play basis. It was a big part and theme of the fellowship in of itself was return to play as a whole, because I guess every Division I setting in the athletic department has their own kind of structure as to what physical therapy's role is. And essentially that's kind of what it was at UCLA. It played a major role in return to play. So that was a very, the focus of kind of what happened.
Yeah. Well, and I think that's a debatable thing. We talk about that all the time as sports PTs. What is return to play? What is return to sport? If you read literature, they're kind of interchanged, that word in general, right? Return to play, return to sport. What is return to sport to you?
Yeah. So just going back to UCLA and my experience, return to play essentially starts from day one, from seeing the athlete in and of itself and the relationship you make with the athlete and the trust that the athlete gains in you, and them understanding what it's going to entail to get to that end point and end goal, as along with the consultation and collaboration from the rest of the sports medicine team. So, over time, bouncing back and forth between myself and an athletic trainer during treatment while someone is rehabilitating, whether it's non-operative or post-operative, having the opportunity to, sit down and talk with the athletic trainer about, goals and certain types of things like that to get to their next level of rehab along the way. So constantly having that communication piece there. But return to play as just a loaded term, it's different from setting to setting, because your typical return to play in an outpatient setting is a lot different from what I'm kind of referring to in the Division I athletic setting, whereas there are a lot of different just resources available and different personnel available at your disposal that are easy to get to and easy to communicate rather than as your typical outpatient. So it's an interesting discussion and an interesting point, but that's kind of, I guess, the segue into what return to play truly is. So essentially, depending on what sport, we're always thinking about what sport we're returning back to and, what activity we're returning back to also. So it's not just return to play at the end, it's return to several activities along the way too. So, there are a lot of different things we can touch on. Is there anything in particular where you'd like to start with it?
Well, I think I'll tell you what my view is it's a continuum, and we've heard that slowly over the course of years, but there's a model out there that's been, there's multiple models. If we think about return to sport, where it started, right? It started with these papers from doctors back in 2000, 2010. They're starting to move toward, doctors and physicians should be the ones that are making those return to play decisions. Mm-hmm. Over time, 2012 is when we first started seeing this shared decision-making process. And, then we had the first world of sports physiotherapy, come together in 2016 and talk about, okay, return to play is not just this one time that we put this like testing battery of like hop tests together and they're good to go. It's not like that. It's a continuum. It's a return to participation, return to sport, return to performance. Mm-hmm. And that's personally how I view it. And that's personally what I explain to my athletes on day one, especially at the professional level, to say, hey, listen, my goal, if I use a basketball player, I like basketball. So if I use basketball, for example, I'm trying to get them on the court as soon as possible doing something, right? So I'll give you an example. If I have a basketball player that's returning from an acute soft tissue injury, let's say hamstrings, whatever it may be, I'm going to have them start working on the court as soon as possible, but they're going to be playing offense first because it's pre-planned movements, right? I'm going to keep them out of that reactive stuff with their individual coaches first. I might, in fact, have them do 5v5 before I have them do small-sided games at 3v3 or 1v1, just knowing the energy system demands and how much more conditioning they're going to get from 3v3 and 1v1 versus 5v5. Does that make sense? So it's again, and we can take this a million different ways, but how would you take an athlete, let's say basketball, football, whatever your passion is, and explain how you kind of go through that continuum on your own?
Absolutely. So I think of return to play as a pyramid, essentially, and being as objective as possible when progressing through that pyramid. And just to give you an idea about what I'm talking about is, thinking about the baseline of the pyramid are basic principles and foundational principles of rehabilitation. Someone comes to us, they come with, let's say post-operatively, they're coming in with something. We want to make sure we have that pain under control, swelling, effusion is under control, range of motion, general mobility, having those baseline principles of rehab knocked out, making sure that they're well taken care of before progressing onto that next level, which would be more of our dynamic movements, double leg, single leg, those types of things, and making sure we objectively keep checking up on our baseline level of rehab, not forgetting about it, and then continuously moving through that pyramid until we get to the very top. So to give you an idea, objective baselines at the bottom, double leg, single leg, dynamic movements in that next phase, eventually getting to that return to run piece, and really kind of taking somebody from using whatever objective biomarkers that you may want to use. I like to use, me in particular, lateral step down test, depending on the sport of demand and the demands that we're looking for. So basketball, thinking about at a faster pace, maybe, since, thinking about the time of play and an average play, versus a soccer player who's running all over the field consistently nonstop. You may want somebody to do a lateral step down test for 2 to 3 minutes at 60 to 80 beats per minute, however it's validated. And making sure that they have that good neuromuscular control, dynamic balance, reaching terminal knee extension, making sure that their foot and ankle control is good. So you're always looking at these types of things as we're progressing through each phase, showing competency and really owning each movement as they progress forward with no pain, with no swelling, with good mobility, with good control, along with our strength and power development along the way, which is kind of just a side kind of track up as that's going to progress as we progress our activity level. Until we get to, those more dynamic return to play tests, such as hop testing and all those types of things that we know are out there. I always like to reference it's a test retest inter-rater reliability article from JSPT several years ago, functional lower extremity evaluation. It's the FLE article in short. A lot of rehab directors and sports med providers from Pac-12 collaboratively, got together and decided, hey, what are our greatest tools? And this is just for the lower extremity. That's another discussion for a different day, because the spectrum for spine return to sport and upper extremity is completely different from lower extremity. And who's to say that these tests are even great as it is? So, it's such a difficult discussion, because, what I would do is different from what somebody else would do, but that doesn't necessarily mean that it's wrong, because there is no true gold standard. So using our best clinical judgment and making sure there is a objective way to go about this, having as much objectivity to decision making, that's kind of the way I go about it, is be objective, make sure you have your foundational principles there, and make sure you understand the athlete's responsibility in the performance time. So getting back to peak performance, understanding what they need to get back to, and trying to mimic that as much as possible. So if I can keep bridging off of that at that very top of the pyramid, and I just mentioned performance, bridging the gap from rehab to performance, is a challenge that I find, that I even find myself sometimes understanding and putting someone through, movement specific, movement skills, movement preparation for on-field specific tasks. So building tissue capacity and load capacity in an on-field environment too. Now I'm just talking about movement specifically, cutting, running, jumping, cross steps, drop steps, decel, excel, all those types of things that they need to develop capacity and load to with their foundational principles of rehab maintained. But then also adding in, like you said, the variability and the cognitive effect, and making sure that you're having a variable environment and reactive time and those types of things. Because we know that a lot of the new evidence coming out, especially with ACL reconstruction, the visual system and visual input has a different impact on our actual motor cortex and the output it has, and the efferent system that to our musculature and the reactive time that we have. So the visual system, making sure we have that stimuli in there, makes so much of a difference too, which is not much evidence to show, visual training and return to play. But, we see all these things such as the Witty Sim and a lot of these reactive time boards that, I think we could see in the future eventually leading up to those, late phase 4 return to play, final stamp of approval, adding those types of things into there. So it's an exciting conversation that I think still has a lot of room to grow for sure.
Yeah, no, and you bring up a good point, because it's not just evidence-based practice; it's practice-based evidence that hasn't caught up
Yes,
yet,
sir. Yes,
right?
sir.
And I think that's what sometimes you see. You see different sides of the spectrum, right? You see the people that are like, oh, only evidence-based practice, and then you got other people that says, well, we've been doing it this way forever, and it's kind of both. It's got to be across the spectrum, depending on the athlete, like you said, and what their demands are, right? And so
Absolutely.
you're in a unique situation right now, because you're at Exos, correct,
Mm-hmm.
in Los Angeles. So
Mm-hmm.
tell me about how that is, because I'd imagine you deal with strength coaches now versus
Mm-hmm.
a typical private practice setting. Tell me how the integration is there, and how that's helping or not helping. What are the challenges and the benefits?
Absolutely. It's a good question. And I think that's one of the main reasons why I was so drawn to Exos to begin with, is the similarities between the Division I setting where I came from at UCLA and what I'm going through at Exos right now. Is the structure is fairly is similar. So Exos, for those of you who aren't familiar, Exos is a human performance company, not just catering to the athlete, but catering to humans in general. It just so happens that Exos has a large sports performance component to it. With its history, but there are 5 main legacy facilities that we call them, that have 3 disciplines under one roof, and Los Angeles is one of those facilities where I'm at. So there's physical therapy, and I'm the only physical therapist in my location, but there are other locations with more than one PT. I work with 2 strength coaches, and I work with a performance dietitian, and together we collaboratively, just like in those types of Division I settings, professional settings, we collectively manage these athletes in terms of maintenance of injuries and continuing to play, or return to play in general, getting somebody post-operatively, connecting with a dietitian, making sure they have the proper nutrients and nutrition for tissue healing, for early phases, for inflammatory processes, things like that. And then, having that integration piece that you mentioned before, making sure that they're able to do the proper and appropriate things with strength conditioning coaches and performance coaches, as they return back to those higher level movement skills that they will be doing in those late phases, just as they're returning to play. So, making sure, like you said, they're able to do something, getting on the field, making them feel like they're an athlete and they're not just rehabbing this whole entire time. Make it seem like it's not rehab, so making sure that the performance coaches were always on the same page. And I think that one of the benefits being under the same roof is, having meetings weekly, touching base with each other, making sure, hey, how did John do today? How did he look on the field? How does movement look? And then me being able to actually go up there and bounce ideas off of them, see them coach sessions, see them take them through the movement skills that they're cleared for, things like that. So it's a unique setting where you get to collaborate and integrate yourself, bridging that gap from rehab to performance. So I think that is a major plus of the position I'm in right now. I really enjoy it.
Yeah, no, definitely. And it sounds ideal from that transition you made from a Division I fellowship, which is doing essentially mostly that, into a position like that where you have that opportunity to. And I think what's interesting about that is not only can you see them through the whole process, but you can see where the other pieces of the puzzle work. Because I think one thing that sports physical therapists struggle with is finding that happy balance of strength and conditioning with rehab, and trying to bridge those gaps. And I've been lucky at times where I've been a performance director and a sports physio at the same time at my company, and building through that, I've been able to do both. But not all places are set up like that,
Mm-hmm.
and there's other times where even if they are set up like that, it's very difficult to be able to get out on the field, for example, right, and do those things, right? And that's, in an ideal world, we would see those things. You have access to that, which is fantastic.
Yeah,
So
it's definitely an important piece that, a lot of people face challenges in the outpatient facilities and the outpatient setting, whereas, the resources and the time that you actually get to spend with the patient is different, just because there are different demands to be met in that environment. So it's definitely a challenge. So I'm grateful to be in the position I'm in, to really try to, exemplify what exactly return to play is, and make sure that, it's done the right way, with, the right everybody playing their right role. So it's a great opportunity.
Yeah. One question to kind of piggyback off of that, with return to play testing, what is your thoughts on that? And how do you go about that in your current setting?
Sure. So return to play testing, like I said, I'm going to bounce back to the pyramid and making sure that, we have our objective biomarkers. Return to play testing is something that kind of collectively happens on the continuum of treatment. So from, like I said, visit 1 until the last visit, I'm always objectively, getting quantitative values to, understand where they're at, symmetry side to side, making sure that we understand quad to hamstring ratio, understand we, have limb symmetry index of quad strength, of different types of musculature in lower extremity, upper extremity, whatever we're turning them back to. Making sure that qualitatively we're assessing and identifying movement patterns and making sure they have the proper neuromuscular control to develop the capacity to move within the pattern the right way so that they can build resiliency to athletic movement on the field. Now, understanding that, there are certain tests that people do, I like to use a multitude of tests as one whole, say it's before we put that stamp of approval to say, hey, you're good to go. But understanding that after we have those tests under the sun and things look good, they do a self-reported outcome measure, we're getting as many ideas from different avenues. The MD is getting involved because legally we need them to stamp the approval and say, hey, you're good to go. But knowing that there needs to be capacity and a gradual load management to schedule them back to full participation versus, hey, you can go back to practice. That's more of that return to run, practice-specific activities, those types of things. Then getting to that next level of, okay, now been in practice, you look good, your movement looks great, you've been working with strength conditioning for a while, performance training is going great, you have no pain, you're passing all these tests, great. Now you can go back to a game, but does that necessarily mean they're allowed to go back to a game 100%? So building load capacity within that level to get them back to that hierarchy. So those are the types of conversations that are important to have with my athletes, saying that, hey, just because you're good to go doesn't mean that you're good to go. Making sure that we build you up so that we have that good chronic workload that we can build up over time. So not only I feel confident, but you feel comfortable in your own body too. So knowing that, kinesiophobia is an effect, and depending on what they're coming back from, psychologically, they need to be ready to go too and have confidence in their bodies. So it just shows them that they're also able to do it too. So, always being careful not to throw somebody to the wolves and making sure that they're ready to go from a time standpoint, but also objectively too.
Yeah, no, absolutely. I think it's important to, and you alluded to this throughout our conversation so far, that you're always objectively testing something, right? And the way I always explain it to people is I have not just one test, I have testing batteries along the way. And I keep retesting the same thing and the same way I'm testing it, because I think that's almost more important than the actual test you choose yourself, because you need to constantly be retesting what you've already tested so you can show progress or show them, hey, maybe you're not quite ready yet, or you're ready for something here. This can give you some confidence. Right.
Absolutely.
You also alluded to like quad to strength, quad to hamstring ratios. How do you test strength?
So essentially what we do, I am not as kind of just as a physical therapist and literature in general, reliability, intra and inter-rater reliability of MMT using my hands. I don't feel comfortable as a clinician being able to assess someone's strength like that. So I'm fortunate enough to be able to use a handheld dynamometer, which, we know that isokinetic dynamometry is essentially the quote unquote gold standard for strength testing. And the amount of metrics that we can get and the principles of musculature and performance is quite substantial. And there's a large body of evidence to support that. But the next best thing I would have to agree with, handheld dynamometry would be it. So I use handheld dynamometry to gain those types of metrics, and I make sure that the variability between tests and between raters, that there is subject to a lack of reliability. So making sure that I'm reliable between tests. I typically use my handheld dynamometer with some sort of mobilization belt to actually stabilize. So I'm not using my arms, and, between sessions, maybe my shoulder's hurting one day and it's not hurting, you know what I mean? Using the wrong arm. So making sure that I'm trying to account for those variables too. So I do enjoy measuring strength with those types of instruments, just so we can be objective with it.
Yeah, no, that's great. I think that's so crucial. And these are the reasons why I ask people these questions, because I think it's worth the investment of the 800 to 900 bucks that you have, because guess what? You're going to use it forever. And like, you have something you can truly say objectively then, versus again, MMTs, which don't tell me anything. The other thing that I've been playing around with is, and I learned this from a different physical therapist, is a crane scale, and just hooking it up to like a tricep straight bar, trying to do like an isometric mid-thigh pull with like a chain underneath. Hooking it up. I've been playing around a little bit with like leg extension machines, different angles.
Absolutely.
I'm not quite awesome at it yet, but I'm getting there, and it just gives force more than anything. So it gives it something to measure. But yeah, I think it's so important to be able to have these objective measures and to take the time to do them, so you can actually say, okay, I actually have a true reason for saying I think they're strong.
Absolutely. I mean, handheld dynamometry, having access to a NORD board is huge too. So we, with our NFL Combine program that we have going on right now at Exos, we just started to implement that into our objective testing that we do, just as an intake to identify and try to flag people who may be at risk for some sort of hamstring injury, identifying large asymmetries, starting to address, trying to put them through some sort of algorithm to, get some sort of normative scale and standardize, someone who's a 180-pound, 185-pound D-back to a 300-pound, offensive defensive lineman. They're going to have two completely different hamstring outputs for torque and strength. So it's making sure that you're being objective and you're standardizing and accounting for reliability. So whatever system that you're able to use or have available at your disposal, important to just try to be objective with it. I mean, it really boils down to it, because we don't want to have a discussion with a physician after someone gets hurt and, well, what made you want to make that decision? Well, they just looked pretty good and they felt pretty strong. I don't know if that's necessarily good enough. And that kind of leads me to my next thing is like, hey, 90% limb symmetry, is that necessarily good enough too? Is that good enough with the fail rates that we have for ACL and re-injury rates that we have for certain pathologies? Should it be 100%? Should we be utilizing more wearable technology? So at UCLA, for instance, for some of my return to sport for spine patients, looking at, I utilized a system, I don't know if you're familiar with it, called the Dorsa V movement system. So where I kind of fell in love with using those types of things, and found that they were well validated with some of the higher ups in the field of wearable tech. And I found that the quantitative values that they gave you are super useful. Whereas qualitatively as a physical therapist, we may be missing even like those tenths of, a degree, which could be a difference. Being able to measure someone's single leg squat, single leg hop with, degrees per second of dynamic valgus could be the difference of how well they can control that movement within that, adduction to IR, moment. And that could be, make or break. So I like to see return to play moving a lot more in that direction, but not forgetting about what we do as PTs and how we can qualitatively assess. So I think it's exciting. Like I said, I'm excited to see what's going to happen in the future with return to play. I think it's only going to get better and better from here on out, hopefully.
Yeah, no, I agree with you. This is great. We could talk about this all day. I think you bring up some great points, and I know we share some very similar views on this. So this is great to talk to you about all this return to play stuff and hear your journey with the Division I fellowship, how that's influenced you, how Exos is going well for you. Last question for you, and then we'll kind of wrap it up.
Yeah.
Where do you see yourself in 5-10 years? What's the goal for you? You've done these things at the Division I level. You're doing some great things at Exos. What are your goals?
Yeah. So I essentially started this whole journey with the goal of eventually moving on to the professional level as a physical therapist. First and foremost, it's kind of been my 5-year vision. in and of itself. My experience at Eagle Big Training Center and my background in wrestling and as a wrestler, my passion for the sport and love for the sport. I coached high school wrestling for a while. I just want to give back to the sport as a whole. So one of the main reasons why I tried to go down that road was to work with Team USA Wrestling. So that is also in my kind of what's called 5-year plan as well, having that opportunity to work with those athletes, which is essentially the highest level of competition for wrestling, as there's no really professional circuit. But at the same time, sports is sport, and I'm a huge advocate for all sports. I love working with all types of athletes, so any opportunity to work with the highest level of athlete has been a passion of mine for as long as I can remember.
Awesome.
For sure. Yeah, absolutely.
Awesome, man. Very cool. Well, listen, this has been great to talk with you. For our viewers out there, how can they find more information on you? How can they, see more stuff that you're given? I know you started an Instagram page. I think it's the sports physio, right? Sports _ physio.
Yeah. So it's the sports physio _ at the end. So okay. I've been wanting to start up an Instagram account for quite some time, and been a little preoccupied with residency and fellowship back to back. And I finally have a chance to kind of get my neck up out of underwater, and I'm excited to get that going. So if you guys are looking for some content or things I'm posting, feel free to reach out to me. You can message me on there. I don't have a Twitter set up yet. Planning on doing that too. So look for some updates on my social media platform for Instagram for that.
Awesome, man. This is a great discussion. Really appreciate you taking the time, and it's been fun. So for all the viewers out there, feel free to check out his Instagram. Otherwise, you can see this and more on the Student Physical Therapist. Thanks again, Zack.
Absolutely, Brian. Thanks a lot. I appreciate getting a chance to talk to you, and speak to you soon.
Awesome.